Hello and welcome to Chapter 25. Safety is our topic today. So we know that the nursing process is the foundation or the framework that we are going to build our concept maps and our care plans for our patients. And hopefully we're going to be thinking a little bit about patient safety in these for their goals. Nurses play a critical role in teaching the patients and their families about how to remain safe, not only in their own homes, but in the communities. And it's our job as nurses, while the patients are in our facilities, to help them be able to remain free from any additional harm and to help them be able to be safe. Also, while we are in our own working environments, wherever that might be, whether you're in a doctor's office or you're in a nursing home or you're in a hospital, you as nurses need to be aware if your working environment is safe for you, and you want to be proactive in keeping it safe. So this chapter addresses the environmental safety concerns of not only individuals but also their communities, talking about home environments and kind of some key principles of maintaining patient safety in the healthcare settings. So safety is your number one concern and priority. All of us like to know that we're safe. We like to feel safe. We like to make sure that our family is safe. And safe just means not only being free from any kind of physical harm, but also mentally knowing that you are okay and that the environment around you is okay and that your family is safe no matter where they are at. The Centers for Disease Control and Prevention, or the CDC, has started a nationwide and worldwide promotion or goal for a healthy healthcare environment and to have it be safe. And the branch of the CDC, which is the National Center for Health Statistics, which is NCHS, is involved in detecting and investigating problems in the U.S. health problems in the U.S. population. In 2007, the NCHS found that the unintentional injuries were the fifth leading cause of death in the U.S. population. This was following heart disease, cancer, stroke, and chronic lower respiratory diseases. Also, injuries and poisonings can also have non-fatal consequences but need required long-term medical care. So unintentional injuries are often referred to as accidents, which are incidents that occur at random, and they may be unavoidable. However, the term accident has also been not used as much lately because the patterns of unintentional injuries are often predictable and in some cases very much so preventable. So the risk factors and prevention mechanisms for intentional injuries are better understood than those of the unintentional injuries. So intentional injuries we understand because they're acts of violence, they're abuse. Somebody intentionally tried to hurt you. Somebody did something that either hurt you or hurt someone you love or hurt themselves. So those are things that are going to happen because the person wants them to happen. Now we can prevent those. We certainly can if we know, and if we're given the opportunity to intervene. Beyond the community focus on injury prevention is the major concern about safety in the healthcare environment. Because of so many changes and how rapidly everything does change, the healthcare environment has kind of taken a little bit of a hit on patient safety. More than a decade ago, To Err is Human, a report that was issued by the U.S. Institute of Medicine, introduced the modern patient safety movement and pointed out that the problem of medical errors in the hospital, how many there were and what some of them were, and the number of incidences that occurred. During the past decade, the Joint Commission has focused on the goal of patient safety. So in 2003, the Joint Commission developed the first set of performance standards addressing crucial elements of operations related to the patient safety. These standards, known as the National Patient Safety Goals, or NPSGS, are reevaluated every year, and every goal has specific elements of performance that every healthcare worker is required to meet. The largest proportion of healthcare workers consists of nurses, and schools of nursing have increasingly emphasized a focus on patient safety in the classroom and clinical courses. In 2005, the Robert Wood Johnson Foundation established the Quality and Safety Education for Nurses, or QSEN. This was a project that had a goal of preparing nurses for the future with the knowledge, skills, and attitudes needed to advance quality and safety on the job in the healthcare settings. The definition provided by the QSEN project states that, quote, safety minimizes risk of harm to patients and providers through system effectiveness and individual performance. In all settings, including the healthcare setting, reduction of risk and prevention of accidents is the overall goal. Individual factors that affect personal safety include those related to how the body works, how it's going to be affected. If you're walking okay, then you're not going to trip and fall. If you have enough strength in your muscles, you're not going to be weak and fall. All those different things. So your body system integrity is important. If it's functioning correctly, if it's doing okay. All aids in keeping you safe while you're in the healthcare center or environment. Environmental factors would be, is it light enough in the room? Is there adequate lighting when they get up at night so that they don't trip on something on the floor? Do they have night lights that are available? All of that kind of stuff. Is there pollution in the area that we need to be aware of? Is our wet floors constantly there? Those are all things that need to be involved in the patient setting. So when you go in to assess your patient, the first thing you want to do is you do a quick review of the room. You want to look at the floor and make sure there's not a bunch of water all over the floor because they dumped over the pitcher from their table. You want to make sure there isn't cords strung across from the bed to the other side of the wall because there's no outlets, and so they had to do that. Well, you don't want that because people can trip over the cord. You don't want blankets all bunched up so that they can't move freely with their legs, so they trip on that. All those different things. You just look at the different environmental issues you have in the room and make sure that it's safe for your patient. Lifespan is another aspect that we look at. Of course, every age has their own special concerns, but the main important thing that we need to be aware of is that patient safety concerns, they are in every facility that we work in, and ultimately the safety of the patient rests in your care. And you need to be able to determine whether or not your patient's behavior is going to provide them with a safe and uneventful stay with you in your facility. Altered safety, prevention of injuries is the ultimate goal. And providing patients with safety information not only gives them the tools they need to ensure that their own safety, but it also keeps you all on the same page so that they all know that you're working together to do this. Keeping individuals safe in their homes and communities depends on, of course, really good education and prevention of illnesses and injury. Specific and home community safety concerns would be food safety, which you teach them as best you can, especially if they're doing canning, not to eat something that didn't get sealed properly and that could potentially have botulism in them. That's the old, grandma died from eating canned beans because they had poison in them. She didn't realize they were poisoned, so, okay, that's the old story. Prevention of injuries resulting from motorized and non-motorized vehicles. Even little scooters can injure patients if they don't know how to operate it correctly. If they're sitting in one of those motorized shopping cart scooters is what I'm thinking about. If they get on an uneven area in their home, it can tip, they can fall, can hit their head. These are things we need to be aware of. These are things we need to help them be aware of. Other specific home and community concerns include the ones listed here: the poisoning, the toxins, the lead poisoning, and carbon monoxide. And we know carbon monoxide is colorless and odorless. So this is how I tell my patients that I'm concerned about that they might have this happening, or if I have a friend that is complaining of constant headaches when they get at their house. They're always getting headaches at their house, but when they're at work, they're fine. Or they seem to feel really cloudy and confused while at home, but when they go outside and drive to the store, or they go outside and drive to their work, and while they're at work, they seem to be fine. Get your house checked. There's something going on inside your house. So environmental areas, just be aware of. Teach your patients to be alert and aware of things. Lead poisoning. We all know the story now about Flint, Michigan, the lead poisoning in the water back there. That's going to have years and years and years of results from that poisoning. There's going to be generations of people affected from this. That's a sad reality. We need to be proactive. We need to be yelling at people if we start seeing the water look different or taste different. We need to be, screaming at the top of our lungs if something like that's going on. Don't just think, oh, there's a problem, but no, somebody's going to fix it. No, be the one that fixes it. Altered safety, we're going to continue talking about some of those other issues. Electrical shock. Now, we all know that if you see a down power cord, you're not going to, or a power line, you're not going to hopefully rush over and try to save somebody out of that unless the power is shut off. So you know that electricity is something that is a concern and needs to be dealt with safely. Hopefully you're going to call the correct people. Some of the things that can occur from electrical shock, of course, are burns, and then, of course, death, because it can totally disrupt the heart rhythm and cause a lot of problems that way. We also know that fire safety is a majorly important thing to teach our families about. Space heaters, candles, children with matches, elderly with matches, smoking in bed, all those different things. Extension cords that are overloaded. Let me think. I'm trying to think of a few things I've seen. All of those can just add to the risk in the family. So teach them the importance of not having those things if at all possible. And if you do have to have them, how to take care of them properly. There are 4 major types of abuse, of course, that we get to also have to deal with, which I don't understand abuse. I just don't understand how people can hurt people, but I guess I'm just in a different mindset than most. There's physical abuse, psychological abuse, emotional, sexual, and financial abuse. Abuse can occur in all socioeconomic regions and areas, all genders, all age, all cultural groups, but some portions of the population are more vulnerable than others. When the economy takes a hit, meaning when we are working, multiple jobs to live paycheck to paycheck, or we're not able to make ends meet and have to rely on others, sometimes that causes more or increased abuse due to the frustration that the families feel. The father can't provide for the mother or can't provide for the children or both. And so instead of being able to maybe work it out within their own selves, they physically take it out on the youngest or the weakest of the family. It's just sometimes they even just take it out on the animals, which is even more unnerving to me, that I still don't understand that either. But that's a soapbox I won't get on. So we need to make sure that we're teaching our patients and our community the importance of reaching out for help, having places available that they can turn to so that they don't have to result in this kind of abuse, that they don't have to turn to this kind of abuse. You have elderly abuse where maybe the family's tired of taking care of mom and dad, and so they just want to put them in a nursing home, and the only way they can think of to do that is maybe not give grandma her blood pressure medicine for the last 2 months, and now grandma has a stroke. It's terrible to think that could happen. It's terrible to think people actually do that, but they do. And it's something that as nurses, you need to be aware of. And as you assess your patients, these are some of the things we need to look at and make sure that if we have a weird feeling that something's going on with interaction that we see between family members, whether it be with an elderly and the children, or with a mom and a dad, or even between the mom and dad and the children, any kind of interaction that we feel is inappropriate or weird or gives us a vibe that we don't understand or are concerned about, have it checked out, have it followed. It's better to do that than maybe miss something. Okay, they also have suffocation here. It's really important that we teach, especially new moms and new dads, the importance of not having a lot of stuff in the baby's crib. You don't want to put a lot of stuffed animals. You certainly don't want to have a lot of blankets. Babies aren't able to undo once they've crawled into something. So you have a little one that scoots and scoots and scoots, and eventually, has a blanket that they've now got bunched up under their nose. It can lead to suffocation very quickly. So education, big part, big part, and something that we can do all the time. Bioterrorism. Never thought we ever were going to have to deal with this. Never thought we were ever going to have to worry about it. but it's out there. And so as nurses, we do need to think about it. We need to be aware of our own environment. We need to be aware of the things that are potentially harmful and things that potentially could come into our area wherever you may be. And you need to know of the situations around you. So knowing your environment and knowing what is potential just makes you a better person. But the whole point of this is just be aware of your area. The Centers of Medicare and Medicaid no longer will pay the hospitals for the cost of additional care resulting from patients falling because they are considered reasonably preventable. This is where your assessment tools come in huge. If you assess that your patient is potentially going to be a fall risk, put them in that category immediately and prevent that fall from happening. Because if a fall happens while the patient is in the hospital or in the care that you are doing, whether at the facility or wherever you're at, that's going to be coming out of the hospital's pocket because the Medicare and Medicaid will no longer cover those illnesses or those incidences because in their mind, they think you should have seen it coming, should have prepared for it. Federal government and accrediting agencies have spent more than 2 decades working to reduce or eliminate the use of restraints in patient care environments. Those of you that have worked as CNAs know that side rails are not used. Please know while you're in the hospital, we do want you to use side rails, at least the top 2. The top 2 side rails are not considered restraints in the hospital setting. Let me say that again. The top 2 side rails of the beds in the hospital are not considered restraints. We want you to use those. They have controls for the patient to be able to move their head up and down. It is what we do with them. We do have them up. It helps them move in bed as well. So please, please, please try to get that out of your head from your CNA work. I know it will be difficult, trust me. But if I walk into a room and there are no side rails up on the patient's bed, I will remind you that that needs to happen. Other restraints that they consider physical restraints are the wrist and the ankle restraints. These can be considered soft restraints. They're padded restraints that we will see in clinical or in lab today. I'll show you the restraints and show you how to apply them. Even though we are trying desperately not to use these on patients, we do have a tendency and times that we do have to use them. It is to prevent the patient from pulling out important tubes such as the ventilator tube. We don't want them pulling that out. That would cause them not to breathe and cause a lot of damage if they pulled it out. If they pull out their Foleys, we try really hard not to let that happen. That can cause a lot of damage as well. Plus, not only that, it can hurt them extremely bad. IV lines, we try really hard not to let them pull those out because there's a lot of blood that can be lost with that. Also, we need to use those for medical purposes. So, if your patient is not mentally able to be redirected and follow your directions not to pull on those things, then restraints can be used, and there is a protocol for those. You do need to have a doctor sign and order the restraints for you. You can initially get them started. You can say, hey, I got a patient not working well, not doing good, pulling everything out. I'm going to put restraints on them. As soon as you do that, then you call the physician and you say, this is what's happened. This is what I've done. I need you to sign the order for me and give me the okay to use these. And the doctor will say, yep, I'll sign them. No deal. No big deal. Just, thank you for letting me know. I don't know if they'll say thank you, but okay. Anyway, Once that happens and you have physical restraints on a patient, it's not like, okay, now I don't have to ever go back in that room again. No, every hour, every 15 minutes, every 30 minutes, whatever your facility's policies are, you're going to be following those to monitor the patients in these restraints. They're not just going to be left tied to the bed. There have been deaths associated with physical restraints. Patients, no matter how feeble they may look, can become the biggest Houdinis I've ever seen in my life. I had a 95-year-old female that weighed maybe, if you were lucky, 100 pounds, maybe. And that lady, I swear, she knew how to get out of every restraint we thought of. We had her in a vest. We had her with a bed sheet around her waist. We had her strapped her ankles down and her wrists down. It was amazing. She was amazing. It ended up being that we ended up just sitting at her bedside. She became a one-on-one, And we just round the clock sat with her, because no matter what else we did, she was going to hurt herself. She was probably going to kill herself. And restraints weren't helping. They were just making it even worse. So those are some of the things that you just have to eventually figure out a way that's going to make it work. Chemical restraints, we try really hard not to use chemical restraints. That truly does take all of the patient's independence and control out. A chemical restraint is never done by a nurse without the physician giving the order to do it. A chemical restraint is a medication that is administered to totally and completely control the behavior of that patient. So there are various types of safety risks for the nurse and for the patient in all healthcare settings. Medication errors can occur in many of the situations. Medications should be checked and double-checked in accordance with the 7 rights of medication administration, which is the right drug, the right dose, the right time, the right patient, the right route, the right documentation, and the right teaching. 7 rights. Please start getting those in your head. The right drug. Make sure it's the right medication that's supposed to be given. And it's the right amount that's supposed to be given, which is the dosage. It's the right time. You have a half hour before and a half hour after. So if a drug is due at 8 o'clock, you want to give it a little early at 7:45, go for it. You want to give it at 8:25, hurry up. You got 5 minutes before it's late. Right patient. Always important to check your patient's name and birth date. Right route. Is it supposed to be oral? Is it supposed to be a shot? How am I supposed to give this? Right documentation. Did I put in that I gave this medication? Did I write it in the chart? Did I click it? Did I scan it? Did I do whatever it is your facility is that you're working at requires you to do to document that medication? And did I teach the patient what it was for? This is your Tylenol to help you not have a headache. This is Ativan because you're anxious and we want you to calm down. Overexposure to radiation or radioactive materials used to diagnose and treat patients is a health hazard and a concern for patients and healthcare providers. Nurses at risk for radiation exposure are typically those who work with patients receiving radioactive iodine treatments or work in areas where special procedures are performed involving radiation. Nurses must be aware of diagnostic procedures that can increase the amount of radiation exposure to themselves and their patients. So you're in the emergency room and you have a car accident that rolls in, and you have a patient that needs x-rays, but they cannot go down to the x-ray department. So the x-ray team comes up with a portable x-ray machine. Now, they need help, and they need you to either hold the patient's arm or whatever. You are going to be exposed to the radiation from that x-ray machine. Grab a lead shield. Put it on. Protect yourself. You don't need extra radiation. If you're in the childbearing years, step out of the room when x-ray comes in if they don't need you to help hold something. If they need you to help hold something, don't do it until you have a lead shield protecting you. You will notice on your radiology technicians and the students, they all wear little badges that look like a little gauge of some kind. That shows how much radiation they have been exposed to. Every time they wear that badge, it absorbs how much radiation they are getting during their shift. It's very important that you don't overexpose yourself to situations like that, if at all possible. You'll learn these things as you go along. It's part of knowing your environment. We also need to be aware of those that are in isolation precautions. There's a reason why they are in isolation. Isolation is to help not have whatever organism they have spread to other patients in the hospital or even yourself. It's very important you know about isolation and you do the isolation correctly. Procedural errors are also a safety concern in the healthcare setting. An example would be a failure to identify the patient when you are administering the medication. Or let's say for instance, you have Mr. Jones and you have Mr. Anderson, and you don't check which one of them it is, but one of them needs to go down to surgery or needs to go down to x-ray for a chest x-ray, and it's Mr. Anderson. But you send Mr. Jones, and nobody checks it, and Mr. Jones just gets exposed to radiation. For assessment for safety hazards and potential sources of injuries is an important first step in the nursing process. You need to be able to assess your environment, know what is going on, and know what are some of the safety hazards. Evaluation includes the collection of subjective information related to your patient's symptoms and chief complaints, also history, environmental hazards and exposures, any objective assessment with a focus on the affected body system. The nurse may discover information that provides clues to the safety issues, such as the carbon monoxide. The clue would be, I only have a headache when I'm at home, or I only get this foggy feeling in my brain when I'm at home. When I'm at work, I'm fine. That's a clue. That gives you a hint what's going on. When obtaining the patient's history, the nurse should inquire about causes of prior injuries, probe a little further into the topic when safety issues are raised. Especially if you are concerned about a possible abuse situation, ask questions that are not, ask questions that can't be answered with a yes or a no. All those different questions, different ways of asking them, get you all the response that you need so that you can put that into your documentation and even bring it to the attention of those that might need it. In your assessment, the health history may reveal factors that place the patient at risk for additional safety concerns. The physical assessment will review issues that should be a further investigation, such as bruises or marks in areas that aren't naturally occurring. So, for instance, if you have bruising on the shins or ankles or head or arms of a child, say age, 2 to 6, let's just say 6, that's pretty normal because they're running, they're falling, they're bruising, they're hitting, they hit their shins on things, they hit their arms on things. That's pretty common. Okay, that's something that probably wouldn't raise a huge big red flag for me unless they were in patterns of a handprint or they look a different kind of pattern, like maybe a cigarette burn instead of a bruise. Those things would cause more red flag. So just knowing kind of what you're looking at and what might be a concern and what might not be a concern. The assessment of fall risk should be completed on admission so that you have a baseline, and it needs to be looked at every single shift so that you can make the changes that occur within your patient also, because your patient's going to change frequently throughout the time that they're with us. The 3 most frequently used tools for the assessment of a fall risk in the hospital settings are the Johns Hopkins Hospital Fall Assessment Tool, the Morris Fall Scale, and the Hendrick 2 Fall Risk Model. I'll just have you look at those. We're not really going to go through those. Every facility has a different one, and so I'm not going to really dwell on these due to the fact that you're going to know your own facilities when you get up there. Other nursing diagnoses related to safety issues could be something like impaired physical mobility, may apply after the safety-related event, such as the fall related to the hip fracture. An illness may result in acute confusion, especially in elderly adults, creating the safety concerns. There are many other nursing diagnoses that are directly related to the safety issues. There are also those that are indirectly related to safety issues, such as illnesses that create safety concerns. So you would have illnesses that create concerns would be like a MRSA infection or MRSA infection. That's your methicillin-resistant Staph aureus infection. Hypothermia, needle stick related to disease. Those type of things are other concerns. Sorry, the scanner came up. That's a bad, sorry. Okay, back to the slideshow. Sorry for the interruption. Some of the nursing diagnostic statements related to the safety are as follows. So you could have risk for injury, with some of the factors being insufficient knowledge of the safety precautions or a cognitive impairment. And then risk for falls. One of the factors could be that they're older than 75 years old, or one of the other factors could be that they already use a walker when they're walking, or maybe they're confused due to the medical problem that they're having. So those are some of the, as evidenced by factors that you could put in there for those diagnoses. All right, so NANDA, of course, we've already talked about NANDA, and hopefully you understand and remember what she or he, if you want to put it that way, is. Before implementing the interventions for the promotion of safety of the individuals across the settings, the nurse considers critical assessment findings such as the patient's developmental level, how well they learn and how best can they learn. So do they learn better by reading something? Do they learn better by having it shown to them? Cultural background, and what is their baseline understanding of the situation right now? So after you take these all into consideration, and after you talk with the patient about what would you like to achieve with this, how would you like to have this be, or what desires or goals would you like to see from this plan that we're putting together, then you can develop the goal for the patient. From the slide before, we had some diagnostic statements that were made, and here could be some of the goals for those nursing diagnoses. Risk for fall, you could have a goal of patient will experience no injuries while hospitalized. That was risk for injury. Or risk for fall, you could have patients' risk for falls will be minimized upon discharge to home. The planning, implementation, and evaluation of interventions to maintain the safety of patients across settings is often best promoted through the use of everyone on the healthcare team. So look at this multiple disciplinary healthcare team flow sheet and see all the various different people that we can have be involved in our patients' care. Team members need to work together, and they need to understand the goals that we're trying to achieve, and hopefully we can all help the patient reach those goals. Following the suggestions in the patient education and health literacy box that's listed here on this slide, some of the other suggestions that can be made to help the patient's environment be safe would be patients should be aware of the environmental challenges, such as changes in the ground slope or unevenness in walking surfaces and curbs. So if you have an environment or a community that has a lot of broken up sidewalks, they need to really be aware of those things. And if there's a residential area that a lot of elderly live in, maybe they need to get together and call the city and say, hey, could you come help work these things out so that we don't have all these uneven sidewalks and broken up curbs and all that kind of stuff. That's being proactive in your environment. When going out into the community settings, patients should be encouraged to take their assistive devices along on all occasions and properly use them. So talk to your patients about how they feel about their canes and their walkers. Some people are embarrassed as anything to have to be reliant on those things, but if you can just encourage them and let them know how much better it's going to be for them to use those devices than to end up with another injury, maybe that would help them be able to be more accepting of those. Reminders may be important for those who tend to leave their canes or walkers in the car when they are only going in for a short distance. Well, only going in for a short distance is also the time that you fall and fracture your other hip. So we need to be encouraging and help them to understand these things. Home care considerations. The role of the nurse in mitigating safety risk is largely one of patient education, and we need to help them understand that so much. Nurses helping patients identify safety hazards at home and in the community usually puts the groundwork there for them to prevent any further injury or accidents happening. We need to make sure that we're in agreement and working with other healthcare team members, and also in the community help with being able to provide facilities that maybe need to be updated. So, for instance, handicapped restrooms at the parks, or handicapped restrooms in some restaurants if they haven't gotten those. Those are kind of some strange things to think about, but it happens. Not recently, but it could happen. Make sure that you're dealing with the home environment with the patient and even the patient's family. If you're sending an elderly patient home, make sure the family realizes that they do have the ability to get handrails installed in bathrooms so that patients can lower themselves down by using the handrails onto the toilet if it's a lower toilet, or even help themselves back up with the use of the rails. They also can have those put into bathrooms as far as the bathtub goes area. So those are all things that we can help family members be aware that might need to be something that needs to be changed in the home for the safety of the family member going back there. Also, there's a lot of elderly that live in homes that are older that do not have nice carpeting, let's say, throughout the whole house. So they've used throw rugs as patchwork for their carpets. And, that's great. It works. But if they're using a walker, those walkers can get caught up on the throw rugs. And so it's really important that you discuss with the family members the importance of having an environment that doesn't have tripping elements in it for the walkers, so that the family member can still get around independently as much as possible while using the walker device. Because if they find it difficult to use it in their home, they won't use it, and that aids in more falls. Whereas if they try to use it and still fall, it even adds more to their, I guess, credibility of saying, see, the walker isn't working. So have the family members provide as much safety changes in the home as possible. Consistent with the focus of the QSEN project, nurses must possess the knowledge, skills, and attitudes to maintain safety and prevent patient injury across healthcare settings. For example, a nurse must have adequate knowledge of the variety of risk factors for falls, the skill to select patient-specific interventions to prevent falls, and the attitude that falls can be preventable. When nurses lack the necessary knowledge, skills, and attitudes to care for the population of interest, the delivery of competent care is at risk, and legal issues related to patient safety may result. Issues of patient safety can be disputed legally, and nurses must ensure that current and proper standards of care are upheld to avoid lawsuits. In addition to being guided by the legal issues related to safety, the professional practice of nursing is guided by the American Nurses Association Code of Ethics, the individual's internal ethical code of conduct, and the state's Nurse Practice Act. Healthcare facilities implement several actions to prevent fires and ensure adequate preparation if one occurs. One example is a no smoking policy. As you know, there is oxygen in every room of the hospital, and it is flammable and should not be used near an open fire or flame at all. Fire evacuation drills and practices in the use of fire extinguishers should be conducted with enough frequency to ensure that healthcare professionals are prepared to properly respond in the event of a fire. When using the fire emergency response RACE, staff members must quickly mobilize to remove or rescue patients close to the fire. The fire alarm must be sounded and the exact location of the fire reported. 911 is usually called by a facility-wide operator. Measures are taken to contain or prevent the spread of smoke and fire, which include closing doors and turning off oxygen. Patients receiving mechanical ventilation should be disconnected and provided with manual respirations with an AMBU bag. An AMBU bag is a resuscitator bag that is used to assist ventilation. After all patients are removed from the area, an attempt may be made to extinguish the fire if it is small enough. However, an attempt to extinguish a fire should not be made if personnel or patient safety would be compromised in the process. To enable successful evacuation, patients should be triaged on the basis of their mobility levels. So if they can walk out, let them walk out. If they need to be moved out by their bed, get ready to move that bed, and it's not going to be a fun move. So you need to know your evacuation processes for the facility where you're at. And most of us instructors will go through those not because we think there's going to be one, just to have you be ready. Those who are ambulatory should be directed to a safe area. Those who are immobile must be transported by bed, stretcher, or wheelchair to that area. When using the fire extinguisher, it's helpful to remember the acronym PASS, P-A-S-S. You're going to pull the pin, which breaks the seal on the extinguisher. You're going to aim at the base of the fire. You're going to squeeze the handle together, and you're going to sweep back and forth action. That is the proper action for that extinguisher. There are various types of extinguishers. You need to know which one you're going to use, and you need to know where they are located in your facility. The risk of an electrical fire and shock is huge, especially in ICU, where there are so many equipment usages and wires and tubes and fluids and all sorts of stuff. So to ensure fire safety, nurses need to regularly check for faulty and loose wiring that may be attached to some equipment. If there is such a thing that happens, if you see on a power cord that it looks like it's frayed or coming apart, you need to remove that equipment from the room. You need to label it and put it in a room for maintenance to pick up, and you need to email maintenance and let them know that it is there for them to come and fix. Do not use that device until a new one gets placed. Go find a new one. You do not want to put yourself or your patient at risk of any kind of electrical shock due to a faulty piece of equipment. The routine use of three-pronged grounded outlets and plugs on equipment in healthcare settings helps to minimize the risk of electrical exposure, but it still can happen, so just be aware of that. Falls Despite the need for comprehensive fall prevention programs, many interventions are simple and involve manipulation of the environment by the nurse to meet the patient's needs. So when you first walk into your patient's room, it's so important to always make sure that their call light is within reach, that they're not having to reach over and grab something too far away, that their water is close enough to them, that they have the devices that they need on the bedside table or at the bedside so that they can reach it. Make sure you check on your patients hourly just to make sure things are going okay. Make sure they don't have water on the floor that they can slip. Make sure they're not using just plain socks, but have socks that have gripper pattern on the bottom so that they don't slip and slide on the tile floors. Make sure patients are educated in the process of calling for help and waiting for the nurse to get there to help them go from the bed to the bathroom. Having adequate lighting in the room, that's another thing that's really important also. Also, you will realize and see in your practice in the clinicals that people who are at extreme high risk for falls will be placed close enough to the nurse's desk that the nurses or the secretaries or whoever is sitting at the desk will have eyesight on those patients immediately and can keep an eye on them throughout their stay. And that is one of the other really nice things that can occur is having them be watched. You need to ensure at all times that you intervene in the care environment to prevent patient safety by making sure that the brakes on the beds are on and secured and working, that the locks on the wheelchairs are working when you go to either transfer a patient from the wheelchair to bed or from bed to wheelchair. It's disheartening when you go to assist a patient and the chair moves from behind them. It scares them, it scares you, and it might even end up hurting your back in the process. So it's always important to make sure you check those things. Other environmental adaptations that have been made in a lot of the healthcare facilities and especially in shower areas are these grip bars. They are wonderful to be able to help patients pull themselves up off toilets. They also have toilets that are a little higher in sitting purposes, so it makes it nicer so that patients who have had hip surgeries do not have to go as far down to get to the toilet, which is nice for them. They're not having to bend as far. They also have what we call toilet risers that we can add to toilets if that is needed. So these are things that you would assess and that you would be able to identify in your patient's room for your patients. So these are all added things that have helped in being able to provide safety and security for the patients. Special precautions are taken for any patient with a history of seizures. There's extra padding that we add so that the side rails are not the typical plastic and metal side rails, but they actually get padded so that if the patient does have a seizure and if they tend to hit the side rails, it will be padded and they will not hurt themselves. Oxygen and suction equipment is always kept at the bedside. During a seizure, a patient should be protected from injury by placing the head on a soft surface, turning it to the side to prevent aspiration, and by moving sharp or hard objects out of the way. Please do not try to keep the head in one position. Please do not try to keep the airway open. Just tilt the head to the side and let that be the only movement that you do on their bodies. Do not try to hold a patient down while they're seizing. Do not try to move them in any way other than to make sure they are safe from maybe banging into the bed or into the wall situation. Just make sure they're as protected as they can be. There are things called bed alarms that we can use where if a patient tends to get out of bed without assistance, we can put an alarm on so that it senses whenever the pressure changes in the bed, it will go off. And this way we can be right in there to help them and prevent them from any kind of falls. This is one way that we can not have to put them in restraints, which is kind of nice. Some of the other alternatives that we can use instead of physical restraints would be to provide distractions. So music, television, sometimes my demented patients, I would give them a stack of washcloths and I would have them fold those over and over and over and over and over. And it was really interesting because not only did that calm them, but it gave them something to do and they stopped picking at their IVs and stopped picking at the Foley and all that kind of stuff. They kept their hands busy and that was really kind of nice. Try to find some relaxation things that they might enjoy. Maybe a back rub would be something that they would like. That might help relax them. Sometimes aromatherapy is something that patients might benefit from. Sometimes they need a one-on-one person, which is that observation person that just kind of is there to make sure they don't hurt themselves. It's not that you have to be, like an armed guard or anything like that. You just have to, be there, be present, be right there. And once in a while, reach up and touch their arm and say, "You doing okay? Okay, well, I'm right here if you need me." So it doesn't have to be anything really significant. It's just to let them know that somebody is there. Also, minimize the amount of stimulation. If somebody is really irritated with a lot of interruptions in a room, try to decrease the amount of interruptions. Cluster the care. Try to, make events happen all in one session instead of going in and out and in and out of the room. If they don't like all the loud noises or beeps or lighting or whatever, try to remove some of those so that you can help decrease that stimulation for them. A Hallmark study of falls and restraints revealed that with restraint removal in nursing homes, the risk of falls or injuries did not increase and the risk of minor injuries significantly decreased. The Joint Commission patient safety standards focus on using physical restraints very infrequently and only after the many alternatives have been tried and used and have been totally exhausted. After all restraint-free alternatives have been exhausted in consultation with other members of the interdisciplinary care team, such as maybe the nurse practitioner that's watching over this patient or the physician, or if there's a family member that can come and sit with them, if that's been all exhausted, then maybe finding out some other different steps that can be done before using actual physical restraints. In the event of an immediate threat or harm to self or others, the nurse can apply a physical restraint without an order from the primary health care provider, but the order must be sought within an hour of application of the restraint. The interventions and their corresponding rationales provide guidance for the safe restraint application and measures that can be taken to prevent untold consequences. So these are some of the ideas that are the reason why we would want to use medical restraints. Or not medical, physical restraints. These are some of the people that we would have. Now, the unlicensed assistive personnel, that would be your CNA. In this book, they address it as an unlicensed personnel. I'm not really sure why. It is your CNA. We don't really have any unlicensed assistive personnel in facilities here. So anytime you see UAP, please know that they're referring to the CNAs in our lectures. Some of the things that the CNAs can do is they can notice if the hands are getting more swollen from the wrist restraints, if there's open lesions underneath the wrist area where the restraint is because of them pulling and chapping the skin there. If they are noticing any kind of numbness or tingling, if the patient's reporting that to them while they're in the room, or any changes in the basic vital signs of the patient, those are all things that need to be and should be reported immediately to the primary care provider. So you as clinical or as student nurses, you can put yourself in that CNA role right there. You will be noticing those things, and if you have a patient in restraints and you see those things happening, then you need to go get that primary care nurse that is going to be working with you and notify them of those changes and concerns. Once those things are addressed, we need to identify them quickly and appropriately treat and remove the restraints and do what we need to do to fix the problem or concern. Evidence-based practice has shown that wrist restraints or any kind of restraint is debilitating to the patient themselves, but if once they are able to understand and comprehend things, then they understand the purpose of them and the reason for them, and usually feel really bad that they've had to be used to begin with. So just look over this evidence-based practice. Waist restraint and the lap restraint are no longer things that we use due to the fact that a lot of patients have had serious damage from those restraints being placed. If you think about it, the waist restraint, it depends on how tight you get that tied to the bed. If they're very active people, they can do a lot of damage internally that we can't see until it's a little too late. So those two types of restraints are no longer in use. The vest restraint still can be used if it is properly placed, and we will go over those in the various different facilities. Again, you have to be aware, family are going to come in and they're going to wonder why you've restrained their family member. You need to be able to politely and very non-judgmentally explain to them that it was for the patient's safety, it was for their benefit, so that they did not harm themselves or maybe harm a nurse or whatever the case may have been. Allow the family member to voice their concern and frustration, and then maybe suggest that they stay with the patient and we can undo the restraints, and they might be able to help us out a little bit with that. Depending on what the situation is, sometimes it only takes once, and then the family members are like, yep, I understand why you restrained him, sorry, thank you, and then they don't ask those questions again. But sometimes they don't understand, and it's okay for them to experience it as well. So as you see in this picture, the top two side rails are used for patient positioning, and in a hospital setting, again, like I said, these are not considered restraints. These are considered useful tools to help a patient reposition. So please have the two top rails up. Use one of the bottom side rails as necessary in certain patient circumstances. So if the patient is okay with it being up, that's fine, it can be, or both of the bottom ones can be down. Doesn't matter on the bottom rails. Just make sure the two top rails are up. Note that when all four side rails are raised, it is considered a form of physical restraint, which requires an order from a primary care provider. As long as you have just three up, you're okay. If you feel the patient needs that fourth rail up to keep them in bed, that becomes a restraint. You need to call the physician, and you need to get an order for that. As with any physical restraint, it is critical to weigh the benefits and risks of the use of side rails. In the United States, there are approximately 2.5 million nursing home and hospital beds. The FDA requires reporting of incidents involving beds with rails. From 1985 through 2013, the FDA received reports of 901 incidences of patients being trapped, caught, entangled, or strangled in rails, with patient outcomes ranging from death to non-fatal injury. Studies have demonstrated a link between the use of side rails and falls. These falls can happen even when the patient is attempting to get up and do something purposeful, such as go to the bathroom. So that is the most important thing of being able to be what I call be present for your patient. Being present for the patient doesn't mean just walking by the room and looking in. Being present means walking in and talking with them and initiating a conversation and checking to make sure things are okay and being present at their bedside. That 95-year-old I told you about, the one that I can't even imagine how she did this. This was before these new beds where the holes in the railings are a little bit smaller, thank goodness. This was the older beds, and they actually had big cutout sections in the bottom rails. And this, well, not really big, but I guess big enough, because she fit right through it, except for when it got to her waist. And then for some reason she couldn't get up on the bed or out of the bed. So here she was just kind of like dangling in this bottom rail. I was mortified. I had just been in the room, and it was just like, oh my gosh, really? What the heck is going on? So people, even though there was a gap between the top rail and the bottom rail, she chose to go through the rail, not through the gap. Then getting her to relax enough for us to be able to get her back through it so that we could get her onto the bed and get the rail down was a joy. Because she didn't understand, and she couldn't figure out why we were manhandling her and why we were pushing her this way and that way. And oh my goodness, yeah. So see, yeah, you're going to have stories like this someday, trust me. A simple measure to promote patient safety and prevent falls is to make patient rounds hourly, to attend to their basic needs, to make sure they've gotten up and gone potty, make sure the water's close enough for them to reach, make sure the call light's available so that they can call you, all those things. Evidence-based practice for side rail safety is just listed here. Go ahead and take a look at that. One of the 2014 National Patient Safety Goals is to improve the safe use of medication. The QSEN project focuses on developing nurses' knowledge, skills, and attitudes, each of which is crucial for the safe administration of medication to patients. Application of the necessary knowledge, skills, and attitudes assists the entry-level nurse in performing safe medication administration. Healthcare-associated infections, formerly called nosocomial infections, are acquired by patients during the course of treatment for other conditions, such as you have a patient that's admitted for pneumonia or gastroenteritis, and urinary tract infections are common examples. So, to reduce the incidence of hospital-associated infections, nurses play a key role in preventing the transmission of pathogens in healthcare facilities. Infections and injuries may occur in healthcare facilities as the result of errors in procedures and malfunction of medical equipment. To avoid these types of events during procedures, the nurse should carefully follow the steps of facility policy and procedure manuals and adhere closely to sterile technique. Routine checks of battery-operated equipment, along with testing and replacement, may be performed by nursing or clinical engineering staff depending on equipment type. So that's talking about your machinery. If it looks like it's not working right, please, remove it and have it replaced. Lead shielding should be used for patients and staff when working with radiation diagnostic or treatments. Staff should be kept as far as possible from the radiation source and the length of exposure limited. Healthcare professionals should wear a radiation monitoring device or badge that is periodically checked for cumulative radiation exposure levels to ensure safety. Those are the badges that I discussed that radiology technicians wear. Successful management of bioterrorist attack depends on the emergency response plans of healthcare facilities. In addition to nurses taking part in public health awareness programs, they should be familiar with the disaster management and preparedness programs of the facility in which you work. So, as we talk about these plans and we know about these, at the very end of all of this, we're going to evaluate it and make sure that as we've prepared our patient for safety, whether it be home, in the community, or in our healthcare facilities, we want to make sure that we can evaluate if that safety plan is effective or not. That's why it's so important when you have hospital drills or fire drills or disaster drills that you participate, that that you're aware, that you're taking part in them, because that helps not only you know the response, but it helps the whole entire facility know the response. And it also helps your patients feel like you care enough for them to know how to take care of them in a disastrous situation. All right, end of this chapter. We'll see you in the next one.